Okay, so we have some cards have come in already, I'm sure, and I have some in my hand. Let's start with Dr. Shaw. We heard a little bit of the word Parkinsonism was used by several speakers, and we heard earlier in the day that PSP and CBD have more in common with Alzheimer's pathology than with alpha-synuclein or Parkinsonism. So why do we call PSP and CBD atypical Parkinsonism diseases? There you go. It should take a second. Yeah, there you go.
Okay. Well, that's a great question. So usually when we say Parkinson's disease, it implies a certain pathology and certain pattern of symptoms, and that's usually slowness, that bradykinesia, rigidity, etc. But usually it also implies that there's this alpha-synuclein protein pathology causing the disease, and it usually implies that a certain type of medication, levodopa, helps improve those motor symptoms. And so rather than be so specific and say, oh, this is Parkinson's disease or not, we might say Parkinsonism to imply the symptoms that we see in Parkinson's disease, such as that bradykinesia, rigidity, tremor, etc. So Parkinsonism can be seen in a number of diseases. We can even see it in Alzheimer's disease as it progresses and advances. So Parkinsonism we can see in corticobasal degeneration or corticobasal syndrome, progressive supranuclear palsy. We can see it in Lewy body disease. So this Parkinsonism can be present all over, but we don't call it Parkinson's disease unless we think it matches all those clinical symptoms for Parkinson's disease, has that pathology, and responds to levodopa. And then with respect to the second part of the question about Alzheimer's disease pathology being related to progressive supranuclear palsy and corticobasal degeneration, I like saying CBD and PSP. They both have tau in them. The tau in Alzheimer's disease, as I mentioned, is this 3-hour and 4-hour tau, so a little bit different than the tau that we see in PSP and CBD, but there is that relationship. Whereas in Parkinson's disease and Lewy body disease, we have this alpha-synuclein, what we call Lewy bodies. And so that pathology is a little bit different, even though we might see some symptoms that look a lot more similar in their symptoms and how we see in the clinic and what you complain of, more than what we see in the pathology. And I hope that's clear.
Okay, very good. Right now, Dr. Shaw, what does it matter if what the patient was diagnosed with? CBD, CBS, PSP, what does it matter?
Oh, great question. Well, besides being sort of academic and wanting to know, I think it helps us understand when we have the diagnosis of what to predict. I think if we have a better understanding of what the diagnosis is, we can better counsel what to expect as time goes by. Some people like the name to the disease so that it can join the appropriate support group, that sort of thing. And also, if we have the right diagnosis, there are plenty of clinical trials that are coming up. They would say, oh, do you think you have PSP? You'd fit this trial. If we think it's corticobasal syndrome, sometimes because the pathology is so varied, maybe they're not recruiting for that kind. So all of that can be helpful in treatment. And sometimes there are different treatments, medications specifically for different types of diseases. Parkinson's disease, as I mentioned, we give you levodopa. We don't expect levodopa to work for PSP or CBD necessarily. It might, but it may not be sustained.
Okay, and one more question for Dr. Shaw. You mentioned the new diagnostic criteria for PSP and that there was also new diagnostic criteria, or at least a typology for CBD. How does knowledge about these types help lay people?
So, well, I think it helps the researchers, the clinicians understand that there are different variants. As we discussed, so many different patterns of symptoms can actually end up having this PSP or CBD pathology. So it helps us understand, and then we can help counsel you when you come to the clinic and understand that better. Some of these tables are really quite complicated, so it doesn't matter that you're a level 1 or a level 2 or that sort of thing. It just gives us greater certainty as to whether we're telling you the right thing in the clinic.
Okay. Megan DePuy, you kind of set us up to say something about LSVT Loud. That's the speech therapy program for Parkinson's disease. Can it be helpful at all in PSP or CBD?
Absolutely. So it's been shown to be helpful in many different neurodegenerative diseases now. And for those who don't know what it is, it's a program, it was originally designed for Parkinson's patients, but it's it's trying to change the perception of speech loudness over a short period of time, high frequency sessions. So it's 4 sessions a week for 4 weeks, 16 sessions, where we're trying to kind of jumpstart someone who has maybe not been speaking loudly for a period of time, or they want to maintain the loudness of their voice. But it's absolutely shown to be helpful across neurodegenerative diseases. I have used it several times with patients, PSP, CBD. I actually have sent many of my clients to be reevaluated after doing LSVT because I see many of the clinical symptoms of PSP or CBD that perhaps a neurologist didn't pick up on the first time, being such as decreased motivation, apathy. A patient I just treated had come from Spain, from a small town in Spain, and was here for a short period of time and wanted to do LSVT, did LSVT with them, and then I saw other clinical symptoms, maybe a little bit observation, but things picked up on, like him falling back onto his heels instead of going forward. So I said, you know what, I think you should go be evaluated for the atypical form Parkinson's. So yes.
Okay. You mentioned the epiglottis in your beautiful anatomic display there. How can you strengthen or exercise your epiglottis, or can you?
Okay, so there's no way to get in there and like do little, barbells for the epiglottis. However, the muscles that are attached to the epiglottis go all the way around your larynx pharynx. And, you have many different muscles in the larynx pharynx area. So you want to try to strengthen the muscles that pull that epiglottis back and forth so that it helps indirectly with the flip of the epiglottis. So you want to be able to move that larynx up and down, which will help that epiglottis. Sometimes it's not possible to strengthen the epiglottis, but if, let's say, for example, you're able to strengthen the vocal cords, if there's nothing you can do for the epiglottis, if you're able to strengthen the vocal cords, like I said, the epiglottis is only one protection mechanism. The vocal cords are like the second level of defense. So let's say you can't strengthen the epiglottis, but you can strengthen the vocal cords, then you're able to prevent an aspiration pneumonia.
Okay. Why can a PSP or CBD patient sing but not speak?
Okay, that's a great question. And I loved presentation saying that music was so important and why is it so important. So when I worked at the Aphasia Research Center in Boston for a while, and they were talking, there was always talk about how the right hemisphere is, your music center, left hemisphere, speech and language center. And so by using music, you can cross, the networks, if you will. 2 hemispheres. You can use the strength of the right hemisphere to pull out language. There's a program for aphasia called melodic intonation therapy. That's, the premise of it is that you're using your musical center to help with speech and language fluency. So often someone can sing because where your ability to sing comes from is in your right hemisphere, versus where your ability to speak and the fluency of your words is in your left hemisphere. So a lot of times someone will come in and they'll say, and then I'll say, sing happy birthday. And I'll say, happy birthday to you. And people are, but it makes sense because they're different parts of the brain.
Okay, Erica Pitsch, I've got a few questions for you. You mentioned the balance or the struggle between letting somebody be autonomous versus safety and security. If someone does not have dementia, let's start there, and someone with PSP or CBD wants to go horseback riding or wants to be walking on their own, what do you say to the family caregiver? Do you say, just be as careful as you can, and hey, it's your family member's decision, or what would your counsel be?
I think just like in research, there's a document you sign when you enroll in research that's an informed consent, meaning by doing any research that says these are the risks, these are the benefits, I understand this, and you sign and say I understand these risks. I think that's a really important conversation to have with any sort of risky endeavor. And so for me, now I'm going to go have like a little contract with the patient and say, okay, classic example, because we see this a lot, like using the walker or not. You know, in our evaluation, your walking speed was, without the walker was this, with the walker was that. Without the walker, I caught you 5 times. With the walker, you maintained your balance. And so really showing objective data in terms of, risks and benefits to each one. Another phrase that sort of came out of the Atul Gawande talk was, I am worried about, or the consequences of failure. It's like, okay, so if you do go horseback riding, worst case scenario, what's the worst that could happen? You fall off a horse, right? And you'd be dead. You can have a brain injury. These are the consequences of failure. If you are okay with the consequences of failure, if you're okay with all these risks, that is your decision. You may have to sign saying you are going against medical advice. But as long as if they are full, if they have that capacity to make their own decisions, that is their own decision. But you just want to make sure that you are fully informed by the risks and the worst case scenario. What's the worst that can happen? I hear that a lot. Oh, I've had a bunch of falls. They haven't been bad ones. Yet. Exactly. Yeah, all you need is one bad one. But, if you're okay with a couple bumps and bruises, we hate it as care providers because our job is to protect. But that's ultimately your decision.
Okay, I have a related questions for you, Erica. Why do people with PSP fall backwards? And what are mobility, can you say something about the options for walkers or mobility assisted devices for people who do fall backwards?
And in answer to the first question, and number one, the first question, really good one. Why do people fall backwards? I don't actually know the answer to that.
Dr. Shaw?
Dr. Shaw, anyone? Have a...
Well, there's
You want to use the mic?
I don't have a perfect answer, but the axial rigidity, which is that stiffness in the body, makes us more likely to tip over. So you even taught me falling over like a tree as opposed to crumpling down, because we used to work together at UCSF. So that postural instability and that stiffness in the body makes this combination of us most likely to tip. Why backwards as opposed to forwards, I'm not sure.
Yeah. I mean, I know that so for basic balance, you have 3 hierarchies of maintaining your balance. So for example, I couldn't stay sitting for too long. With quiet standing, if we're just here, if you breathe, your ankles are doing most of the work. Just a little ankle sway, your ankles are doing the job of maintaining your balance. If you're on a bus or surfing or something where it stops a little short, then you resort to your hip movement. If you really start going, then you resort to a stepping strategy. And part of it is like with ankles, if you think about the way feet are constructed, you have a whole lot more room to go forward. You have a whole lot more limits of stability to go forward. Going backwards, all you have is your heels. You don't have much there. So it could be just a mechanical problem, but with that, and putting that together with that stiffness, if you drift backwards, you don't even have a hip strategy to save yourself. And that's the big problem is that, as they start to drift, if the ankles don't kick in quickly enough, you don't have the speed to even generate a stepping response. And what can be done about it, that's what's so hard. And I haven't found anything that solves the problem, especially later on when people just start one of the first patients I ever saw with PSP would stand quietly and then just, go over like a tree. If you cannot feel yourself losing your balance, it's really hard to catch it. So that's why I said early on, it's that early intervention. Or even better, prevention. But if we get people early on, that's when we really take the gloves off, where we're doing agility ladders. I am like literally have a tool called the turf cord. It's a bungee cord on a belt. So as you pull it, it gets tighter and tighter, and then yanks you backwards. So you get to practice losing your balance. Do not do this at home. You can do this with a physical therapist. But practicing losing your balance, practicing catching yourself is the best part of preservation. But yeah, there isn't an assistive device that can really stop the severe loss of balance.
Okay, Erica, we have a question here about Medicare insurance paying for physical therapy and, of course, speech therapy. What can you say about struggles of getting Medicare to pay?
Oh, fantastic. And I put this in the handout, too, because there was JAMO versus, I think, CMS, the Medicare payment organization. It used to be the standard is that for Medicare to cover rehabilitation, there was this progress standard that patients had to show consistent improvement over a reasonable period of time. A patient with MS said, I have a degenerative illness, I'm not going to get better, but every time I stop physical therapy, I get worse. And she sued Medicare. And they said, well, we never said that. So they were required to educate providers about the standard. Problem is that this habilitative or maintenance therapy, you can't actually say maintenance, is when you have to objectively prove that someone would get worse without you, which is really challenging. Also, it can't be at a frequency and intensity that can be beneficial on its own. And rehabilitation was never meant to be a substitute for home practice. So usually for long-term monitoring, what I've been trying to work with my patients, or what Medicare should pay for, is if you can document, track this progress, keep track of patients, objectively measuring their functional status, finding problems to solve, and then maybe giving people like a tune-up when they need it. But the key features that you're getting things reimbursed is this need for skilled therapy or medical necessity. Meaning, is there a new thing, a new problem to solve, a new exercise to learn? But once that exercise has been taught, if they're doing it correctly, or if their caregiver can do it correctly, or if they're not going to be able to do it correctly, their caregiver needs to be taught. And that's the thing. Again, Medicare is like the most critical, harsh judgment. It doesn't matter if they don't remember how to do the exercise, because they may not be expected to remember to do the exercise. They need to have a caregiver to be taught to do the exercise for them. But Medicare doesn't even care if you don't have a caregiver to do that. What they're looking for is, what new do you need to do this time? And that's what we always have to argue. And so it's challenging. And so that's why a lot of times the therapists are collecting data, they're timing, they're doing standardized outcome measures, because those are the things that we can hang our hat on about going, hey, you improved by a couple seconds, or you didn't lose ground, you maintained ground for the X amount of time, or you're falling more frequently, now we may need to come in for a tune-up. And so that's what we'll tend to do, is do the tune-ups, because there's also a cap.
Yeah, okay, great. Dr. Moss, have a few questions for you. What about convergence, divergence video games, some of which might be available for home use? Is there such a thing as video games for this?
There probably are. I'm not familiar with them. There's also really simple things to do that can do convergence, divergence, so-called pencil push-ups, which I think because they were designed to be done with a pencil, but you can do with any target. So you start with the target in front of you, and you, like the eraser of your pencil, and you look at it with both eyes, and you slowly pull it in, and you concentrate to keep it close until it splits, and then you repeat. And you can even just do it with your thumb, and then you don't need to find anything to do it with, so the exact same thing. There are more complicated versions with balls on a string. I wouldn't be surprised if there's video games as well. I think all of these different kinds of exercises for the eyes. There is some evidence with convergence exercises that they're helpful. I don't know of any evidence with divergence exercise, but what I usually tell people as a clinician is whether it is harmful. And all of these eye exercises, I don't think they're harmful in any way. The problem can be with some of the supervised eye exercises or the software is that there's some cost to them. And so I have trouble asking people to pay out-of-pocket money for something that might not be beneficial. But that said, if you are interested in spending the money and the worst risk is it's not going to help you, and it's fun, then why not?
Okay, there's a question here, Tony. I may have to ask you for interpretation, or Dale. I have amblyopia that is corrected, so I can't have double vision. However, I have noticed that I close one eye, and it does not give me the same image as the other eye. Can you comment on this?
So amblyopia is the condition when during childhood, for some reason, either the eyes aren't straight or one of them has a different glasses prescription, that the connections to the brain don't develop as strongly. Is that better?
Yeah.
Okay, it's directional, I apologize. So amblyopia is the condition where in childhood, either due to the eyes not being straight or one eye having a different prescription than the other, that the pathways between one eye and the brain don't develop as well. And so typically what that leads to is worse vision in that eye. By corrected amblyopia, I suspect what may be being referred to is when it's diagnosed and either that eye is made to see as well, either by straightening the eyes or by patching exercises where you patch the good eye to strengthen the bad eye, that it gets stronger. But sometimes it never gets quite as good. So there are some reasons that people might not have the ability to have double vision. And by that I mean that even if the eyes were completely separate, they might not have double vision. So one of them is simply that they can suppress. And people who have amblyopia or had eye movement disorders as a kid often have this ability to suppress. And so they just kind of ignore one eye. The other thing that can happen is poor binocularity. So normally we take the vision from both eyes into the brain, and two eyes see better than one. And you can actually, when looking at images on an eye chart, you will see more letters, smaller letters with two eyes than you will with one. But some people don't have that. They have no benefit to using both eyes at once, or some even have binocular inhibition, where if one eye isn't as strong, that weaker eye almost impedes the strong eye. So you'll see better with the strong eye alone. And so I suspect what this question is referring to is that the eyes aren't used together, but the eyes still could be of different strength. And so covering one eye may indeed be blurrier. And I don't think that necessarily relates to the PSP or the CBD, although certainly how the images are integrated could be affected by neurological disease.
Okay. Dr. Moss, one person gave a helpful tip. Because of convergence, our neurologist said to raise the reading material onto a music or document stand. This was an easy fix. Have you heard of that?
I haven't heard of it for convergence, but certainly with the vertical eye movements, because the normal reading posture would be to have a straight neck and then to look down with your eyes. But if you can't look down with your eyes, then you may use your neck, and that could be uncomfortable. And so putting it up straight ahead is going to help you with your neck posture. I suppose you would help convergence if you put it on a music stand that was a little bit further, because convergence is an issue as you come close. So the further away it is, the less you need to converge to look at something. But that's a great tip. Thank you. Okay,
and another question for you, Dr. Moss, about eyelid apraxia. I don't think you mentioned that in your presentation. Could you talk briefly about that?
I didn't, but along with thank you.
Dr. Shaw did. I didn't pay good attention.
We tag teamed and didn't even know it. So control of the eyelids is like control of other muscles, and so there can be some problems. So one of the problems can be decreased blink. So decreased blink is an issue because the eyes are like the windshield wipers of the eye, the eyeballs are like the windshield wipers of the eyes. And so if there's not enough blink, the surface of the eyes can get very dry, and that's actually something that can lead to eye discomfort, as well as blurry vision. And so the treatment is fairly straightforward. It's literally flooding the eyes with artificial tears, which are over the counter, to help replace that natural moistening that isn't happening. Part of that is eyelid apraxia, where it's not that the lids cannot close, but rather that the motor control isn't there to close them. And so the opposite problem of not closing them appropriately is not being able to open them. So there can be an apraxia of eyelid opening where someone will close the eyes or in the morning and just simply be unable to open them, and sometimes have to even use the fingers to open the eyes manually. Other than saying that this is something that we see and I can describe it and explain it, I don't have any specific treatments for it other than to say that often manually you can overcome it, and then the eyes will maintain their new position, because the problem isn't that they're weak, it's simply the control to get that action to happen.
Okay, very good. Dr. Shaw, we had a question for you. Can a concussion trigger PSP or CBD?
So concussions are risk factors for all neurodegenerative diseases, head trauma, concussions, etc. So that can increase the risk of getting Alzheimer's disease, PSP, CBD, and CTE, the one with the football players. So they're all risk. What I described in my patient was interesting because this concussion happened and then we had this decline. So I don't think I've seen this in the literature. I haven't looked recently as to what this inciting event, how it causes this decline. But what we'd expect in a concussion, if there are memory problems or movement problems or anything like that things would be static and not getting worse. But with him, he was getting worse. So it wasn't that it caused it, but it's possible that this was already brewing and this instigated or brought this sort of the threshold to change so that it just sparked something. And I've seen that in other situations with Alzheimer's disease or other movement disorders in which maybe they had a surgery, an anesthesia, or a head trauma or something that kind of shocked the system or the brain and then started this, maybe would have happened decades down the road or 5 years down the road, and then this started happening. So I'm not sure it's completely causal, but maybe just kick-starting.
Okay, Megan DePuy, and is this our last question? Yeah, okay, thank you. If someone is not coughing, what are the signs of aspiration pneumonia?
So there are a lot of different signs: watery eyes, throat clearing, coughing, choking. But often, like I said, and I want to just reiterate this point right now, there is not any overt signs of aspiration or penetration. So in many of the cases that I've seen, someone comes into the office, there is nothing that is saying bing, 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 like there's something going on here. I say, you know what, because of the diagnosis and because the high propensity to have the decreased sensation in the larynx and pharynx, I want you to go ahead, have the modified barium swallow. If nothing else, worst case scenario is it'll be a good baseline for 10 years down the road. Look at both of them. Worst case scenario.
If there's no symptoms, why does it matter? Does it always turn into pneumonia?
So there can be no overt symptoms, meaning, so let me clarify a little bit. So when I say someone comes in, there's no overt sign, that means that you're not coughing, throat clearing, there's nothing I can see physically happening, but that doesn't mean that food or liquid is not going into the airway. So when I am looking at like a modified barium swallow or a FEES, what we're going to identify are the markers for risk for aspiration and penetration anatomically, but also is it happening and you're just not feeling it. So what could be going on? It's invisible. It's called silent aspiration for a reason. It's silent. It's happening. You can see it on modified barium swallow, but you can't. And so what tends to happen with people is that they'll penetrate. Food and liquid will sit on their vocal cords, but it won't get into the airway. And this will be happening maybe months, years. And then one day, one swallow, one time they lean back, one time they fall asleep, something gets into the airway, that causes the first aspiration pneumonia. You know, if you caught it 5 years ago when you could see the penetration happening, you might prevent that aspiration pneumonia from happening. And once the aspiration pneumonia happens, it often happens over and over again.
Okay, thank you very much to our 4 panelists.